All right, good morning, everybody. Ready for another beautiful session? Great. Hopefully you had a great evening yesterday, and welcome back. So we will start today's meeting. We have a great panel. My co-chair here, Dr. Mark Slaughter, you know, everybody knows him, and fantastic panel, and I think it's going to be a fantastic meeting and fantastic session. Mark, you want to say some word, or we just go to the?
Well, yeah, no, we'd just like to thank the Easter Shot Symposium. This is a great turnout, and as we discussed this morning, it's the 5th year, and it's now grown to over 1,000 attendees. So I think it's a real tribute to the organizers, the meeting, and really how important this is to the field.
Thank you so much. So we will just go to the program. So the first speaker is going to be actually Dr. Slaughter. He is I don't think he needs introduction here, everybody knows him, but I'd still tell you guys that he's a professor and chair at the Department of Cardiovascular Thoracic Surgery at University of Louisville. He's also executive medical director of Jewish Hospital and director of the Heart Transplant and Mechanical Assist Services at the University of Louisville Jewish Hospital, but he's also editor-in-chief of ASAIO. Thank you very much, Mark, to be here. It's really our privilege. Please go ahead, and he will talk about the debate post-VAD right ventricular failure, surgical mechanical support.
Thank you very much, and you just used up one of my 7 minutes, so I'm going to go very quickly. And I also will start out with the fact that Professor Donker is going to win because always people favor percutaneous over surgical approaches. So what I really want to do, though, is convince everybody how important it is for recognition, and the idea, though, is that you need mechanical support, not multiple inotropes, prolonged waiting, and wishful thinking. Hope is never a good policy. These are my disclosures. Once again, we've come a long way since Galen. We know much more about right ventricular function, what effects it has on the vital spirits, but a great contribution, but we've come a long way. I always like showing this photo because the idea is when we think of heart failure and shock, we always sort of think of the left ventricle. But the fact of the matter is the right ventricle is also always affected. Now, it may be transient and easily reversible. It may be an acute injury depending upon the situation, or it may be from a chronic injury, subendocardial ischemia, volume overload. But things are going to require a prolonged sort of support to get it to recover. So similarly, I always like to show this because the idea, though, is in patients that get an LVAD, right heart failure is clearly still a common cause of mortality. And actually, I always make the argument and go back, those individuals that are listed as multi-system organ failure, you don't have multi-system organ failure for 4 to 5 years. These are patients that had prolonged RV dysfunction, renal failure, stay on ventilators, get septic. So the incidence of actually patients that die after LVAD support from RV dysfunction and RV failure, I think is also much greater than we appreciate. So does it make a difference? And this is from Dr. Kormos almost 15 years ago, and the answer is absolutely, and this is still true. There's more current data, but the curve is essentially identical. If you develop postoperative RV dysfunction after a VAD, you have a significant increased mortality, and if you do survive, decreased quality of life. There's also lots of debate about sort of early right heart failure, late right heart failure. And the fact of the matter is they're both bad. And as a matter of fact, if you sort of look at the overall outcomes, there's really essentially no difference other than maybe out to 3-ish years if you have sort of late onset, which really is those patients that had chronic persistent RV dysfunction. But the fact of the matter is whether it's early or late, it's bad. And you need to do something about it. And once again, though, is 3 to 5 days of inotropic support, some inhaled Flolan, that is not going to get a chronically injured myocyte to recover. So I think one of the hesitations, though, that we all have, not only as surgeons, but cardiologists and programs, though, is there's multiple sort of slides and data like this. And the idea is if you get an LVAD and then you get an RVAD, quote unquote, the outcome is not good. So we recently actually just published from the STS Intermax registry sort of the outcomes of BiVAD support. And interestingly, though, many of them are temporary support. They're put in late in the ICU after multiple attempts of coming off cardiac bypass. All those things, though, just add to the injury what was already pre-existing RV dysfunction. So I think there's this hesitancy to sort of use mechanical support because of the implication that it puts them in a different category. So the other problem that we have is how do we predict or who should be getting a device? So this is looking at individual parameters, MELD scores, wedge pressures, you can use the ratios. The fact of the matter is they're useful, but an individual number parameter is actually no better than 50-50. So what about scores? And actually go back, Dr. Kormos was one of the first scores. We've had multiple since. And once again, in individual institutions with certain patient profiles, they could be helpful, but they do not consistently predict those individuals that are going to have significant postoperative RV dysfunction. So we know a lot about it now. This is, I don't want to say complex, but it takes a fair amount of time. But the idea is there's RV volume overload, there's arrhythmias, you have the septum bowing to the left, the right, that affects the free wall function. There may have been bleeding, there may have been other sort of ischemia. They're now on inotropes that require increased contractility. But if you look at all these steps along the way, number one is prolonged multiple inotropes, vasopressors and whatnot are not going to make that myocyte recover. So unless it was temporary transient RV dysfunction, that is not going to work. Similarly, is if we think of it as an LV in someone that has sort of what we would think of as what's going to be end-stage LV failure, inotropes don't work. They improve quality of outcome, but they do not improve survival. They actually shorten lifespan. So why would we think it would be different on the right side? So we have to think of it as bridge to recovery, right? We think about it for the LV. Why wouldn't we think about it for the right side? So what are the effects of mechanical unloading? You have decreased myocardial cytokines, decreased neurohormonal activation, so you can read them. But all these things are good, and they're going to result in an improved myocyte contractility. This was work that we did years ago when I was in Chicago using individual skinned myocytes, looking at calcium stimulation and ATPase use. The yellow line is from a normal LV. The dotted line is that patient undergoing mitral repair replacement and low EF. But you can see even though the EF is bad, the myocyte is still okay. And the pink is those patients getting an LVAD. And the idea is that myocyte is very different. But what happens to it when you chronically unload it? That myocyte improves. But the answer is it doesn't happen overnight. It doesn't take 24 or 36 hours, and it's not going to happen with inotropes. So the idea is you need mechanical support. So these are multiple options, and Dr. Donker is going to talk to you about many of them. So the issue, though, is why surgical? And the answer is I can do the same thing in the operating room and not delay implantation. So these are all good therapies. They'll achieve about the same. But by putting a cannula directly in the right atrium or through the femoral vein, a graft directly to the PA, I can completely unload the right side. I do not need an oxygenator. It requires decreased anticoagulation, and I don't have to close the chest, wait, and then go to a hybrid room to put in the percutaneous device. So these patients all need mechanical support if they truly are going to get myocardial recovery and ultimately have a good long-term outcome with an LVAD. And I would argue, though, that the surgical decision, you have to have a high index of suspicion before you start. And if you cannot come off on moderate inotropes, you should not hesitate to do surgical implantation, close the chest, and you can remove it at the bedside. So MCS support is best option for myocardial recovery. Essentially, all patients receiving an LVAD have some degree of RV failure. Preoperative optimization, then assess RV failure risk. I'm not confident that any risk score to independently determine eligibility or the need for an RVAD. Using an RVAD should never be seen as a failure. This mindset only delays therapy. And MCS support gives the best chance for myocardial recovery and improving long-term outcomes. Thank you.
Thank you very much, Dr. Slaughter.